Honor Aging, President and CEO. Thanks for joining us today to talk about the continuum of care, which is a pretty broad topic, but I'm delighted to have the following panelists with us. Mr. Fred Bentley, all the way to my right, who is the managing partner at ATI Advisors. By the way, everybody's going to introduce themselves in a second. A little bit more color. Dr. Ritu Suri, who's a medical director at Englewood Hospital, Optum Health Plans, and is a certified geriatrician and palliative care expert. Ryan Simunovich, who is a area vice president for Gentiva Hospice, and Ailyne Genata, who is VP of Marketing and Business Development at Excelsior Healthcare. Welcome, everyone. Thank you. Fred, why don't you introduce yourself, give a little more color to your...
Sure. So very quickly, Fred Bentley with ATI Advisory. We are a DC-based research and advisory services firm. Virtually all of my work is with post-acute care providers, and within the post-acute space with skilled nursing facilities, long-term care providers. So I'm loving this. This is my this is my jam. And I think most relevant for this conversation, we do a lot of work around growth strategy and revenue development and thinking about, to the extent that there are opportunities outside of kind of the core SNF business, what are those opportunities? Who should you be partnering with? How do you form those partnerships? So yeah, very excited to be here.
Ritu Suri. I always say I'm a physician at heart, and I will stay a physician, no matter the titles, but a geriatrician and a palliative care physician. I am the market medical director for Optum iSNP for New Jersey. I am the chief of family medicine at Englewood Hospital, and obviously I have a practice of my own for the last 19 years.
I'm Ryan Simunovich. I'm the president of Gentiva Hospice. So I've been here now for 15 years and in the home health and hospice space for 20 years. I live in Point Pleasant Beach. Currently, my territory I cover from Maine out to Iowa with about 150 care centers that report to me through my team.
My name is Ailyne Genata. I am the Vice President of Marketing and Business Development for Excelsior Care Group. I actually had been with the company for almost 5 years now. And I had been in the healthcare, skilled nursing, post-acute care realm for 20 years now. Thank you.
Thanks, all. So why don't we jump into this? I think what we want to accomplish today is to give attendees some practical takeaways related to how to work across the continuum of care to not only gain market share, but to improve quality and, perhaps be more fiscally responsible on the expense side. But first, I'd like to start off where all healthcare starts off with, the physician, and ask Dr. Suri, we're going to call this first 10 minutes, where do we stand? So tell us about your perspective. I know it's a big umbrella. Related to post-acute care. We've worked together for years in a different life, and you're not the typical physician. You're very engaged and very aware of your patient's needs. But where do we stand today? What do you tell patients when they're looking for, first of all, do patients ask you for advice on where to go for rehab?
I think, yeah. I'm very involved in their journey. So our office is very focused on continuum of care. So when you ask me to speak on this panel, it is really my passion. As a geriatrician and a palliative care physician, I truly believe the continuum of care is very important. And patients, once they develop a trust with a physician, they will ask you, which consultant, the same way they'll ask you what post-acute provider, what hospice, are you going to be there, holding their hand. So I truly do believe, but this is not a scalable model. What I have in my practice is what I see because, unless everybody is in the value-based world and it is not a fee-for-service world, this is not achievable at this time. But it is my passion project.
So what value-based programs are you involved with that impact the post-acute world?
So, when I started this practice, I made a conscious commitment to, and I signed up for the CPCI program, which is a comprehensive primary care innovation project that came out of the innovation models from CMS, and truly was about bubble wrapping our patients in their entire journey. When they come to the office, if they fall, they go to the emergency room, they get admitted to a post-acute, they need home care services, do they need a home visit from us as a clinician? So are they declining? Do they need palliative and hospice services? So it's the entire continuum. That is what their entire initial model was, that you will bubble wrap your patients. The market forces, unfortunately, do not support that model. So I was just actually recently thinking about, partnering with hospital systems, because we have a lot of hospital systems wanting to partner. And I was talking to them about partnerships, and they're like, oh, we don't want your home care patients. We don't want your SNF patients. So obviously the financial forces are not permitting us to continue with this model, but truly, if you look at from patient's perspective, physician's perspective, provider's perspective, I think this is the true model. But
Great, okay. Ailyne, just to transition to the skilled setting, the landscape has changed dramatically over the past few years in terms of access and education and dialogue with the acute care setting. Maybe you could tell us some things you're doing in your role now that are, helpful to sort of broaden the knowledge base of your hospital partners related to what services you provide and how do you do that, what barriers exist, and any strategies that you can recommend to overcome that sort of tightening of access to decision makers on the acute care side.
So I think for the hospital discharge planning process now, they're going more on the more coordinated and value-based program. What it means is that they're tightening their network. For a lot of the hospital, they're looking to do more of like a network facility for post-acute care center. Within that tightening rope of the post-acute care center partnership, there's also different types of partnership that the hospital would like to be doing, right? So that could be the home care, the medications, the Ps. And I think being that their hospital is very big with value-based, they're also looking at like the different metrics of, post-acute care. That would be your 7-day rehospitalization, your 30-day rehospitalization, and more so like your length of stay. So as part of the strategy, we have to, as post-acute care center, needs to kind of figure out which other ancillary services we can bring in as part of our discharge planning and as part of partnership with post-acute care.
Great, okay. Tell us a little bit about your role in your company.
So I'm the number person. I'm the marketing and the business development vice president. Now, I think that role evolved as the years and as the COVID season happened to where we are now. Back a couple years ago when it was COVID, everything was shut down. The marketers, the business development, it's more so like they just stayed around outside of the hospital. I don't necessarily think that the hospital went back into a full-blown like open situation, an open hospital. I think they are open but not really open. So part of my responsibility as the business development marketing is how do we get to the hospital? How do we have conversation with the post-acute care decision makers regarding our services and the SNF? So we do a lot of meeting. We do a lot of Zoom. We do a lot of lunches. We also do a lot of partnership with doctors. I think one of the biggest part of my responsibility is how do I build partnership with each and every sector, home care, pharmacy, doctors, and so forth.
Great, okay. Fred, from a global macro perspective, we were talking before the conference, what are what are some of the things that you're, would recommend for operators to be looking at in terms of the, the federal funding side?
Yeah, I think the reality is, I'm actually going to say two dangerous things here. One, as a consultant, you never come in and say, hey, everything's looking pretty good right now. That's
You don't want to work yourself out of a job.
yeah,
right?
exactly. But then here's the hook.
Right.
But there are clouds on the horizon.
Yeah.
But seriously, I would say just in the near term, specifically to skilled nursing facilities, we've been getting steady rate increases on the Medicare fee-for-service side of things. Occupancy rates, which used to be a big chunk of my work, was helping organizations figure out how to boost occupancy. That's not the challenge, right? The challenge now is having the staffing to accommodate the demand, but the demand that is there and the volumes are there. So you put those things together, the current environment looks pretty good, at least stable. I know workforce is a challenge, always will be. I think the big things to your question that I would be on the lookout for, they're kind of two. One really big one is the changes that are going to be taking place as a result of One Big Beautiful Bill Act, signed into law on the 4th of July. States are just now finding out, okay, how much of a haircut are we going to get in terms of federal funding? Guaranteed that will trickle down to long-term care facilities in terms of downward pressure on reimbursement rates. So that's, there's a big challenge there. So that Medicaid business, which arguably in most facilities we work with is already a challenging economic proposition, it is going to get more challenging. There are a couple of other changes related to the OBBBA or OBA or OB3, lots of different names. Let me know if you have a better one. HR1, it's another name, related to your workforce, related to states' coverage of home and community-based services. There's some positives in the bill, but I think by and large, really trying to understand what is the potential for Medicaid reductions, and then what do we need to do at the state level in terms of advocacy to try and make sure that nursing homes and your residents are not hurt by these changes. The other big thing, and New Jersey's unique here, but Medicare Advantage has been growing quite substantially. Nationally, we are now at a place where over 50% of all Medicare beneficiaries are in Medicare Advantage. I wish I could tell you otherwise, but MA plans typically, with some exceptions, are going to pay you less than Medicare fee-for-service. They are going to tightly manage utilization. I don't think that changes. Now, New Jersey's different. MA is a little bit lower here relative to the nation, but if you're in New York, if you're in Connecticut, other states nearby, it's significantly higher. Pennsylvania is incredibly high. And I think my big concern is that a lot of the clients I work with are still really chasing after the Medicare fee-for-service business. And that's important. The margins are there, but trying to pretend that we can outrun Medicare Advantage or that we can just kind of stave that off, I think those days are numbered.
What do you think the sort of magic bullet, if there is one, is for Medicare Advantage and SNF providers? Have you seen any models nationally that are, auspicious? And
there are a couple of, there are a couple ways to think about this. One is, well, if we're going to be negotiating with these big payers, we need to be able to go toe-to-toe with them. So we have seen a lot of, and quite honestly, I'm not sure what the state of it is or status here in New Jersey is, but a lot of independent SNF chains are coming together and forming networks. And I won't bore you with all the details, but there are ways to basically go to a payer as, hey, if you want to sell an insurance product in this market and you want us in your network, and you probably do because we're a big part of that of your provider network, then you need to play ball with us. I think that's one way, right? So basically coming together, not losing your independence, but coming together to negotiate en masse.
it's interesting.
One other thing I would say too is, as hard as it is to negotiate with Medicare Advantage plans, they do value providers who can keep readmissions down. So if you're a health insurance company, you are freaked out about hospitalizations. Not to overstate it, but I'm sure from your experience of the Optum, like a hospitalization is just a deal killer. You know, it's 15 to 20,000 automatically. So SNFs that can keep patients out of hospitals and can prove that you can do that consistently, even as you're taking more complex patients, that's the golden ticket. And we've been involved with this where providers have been able to negotiate Medicare fee-for-service, PDPM rates, or even slightly above that, which, is kind of unheard of. You have to be really good. Not everybody gets this, right? But I think there are opportunities out there. Yeah.
So are you seeing the majority of Medicare Advantage contracts with SNFs reimbursing at PDPM rates?
No, it's typically a discount of 5 to 10, 15, not unusual. We're just starting to work with an organization that is getting a 35% haircut off of PDPM. So,
Right
but
now,
you feel data?
Yeah, so the Optum contracts that we are developing for the iSNP programs originally have been all fee-for-service, but right now we're truly going value-based. So,
Yep.
But you have to meet the metrics. It really is about patient engagement, patient and family engagement. That is the biggest criteria. And then be willing to work with the partners and keeping those patients in the facility and really treating in place. So, and your quality scores have to be, there are strict quality metrics that they meet.
Yeah.
And they are willing to partner with you, and there is a upside on the other end.
Yeah, I just heard about, actually one of our clients is contracting with an acute care hospital for palliative care beds. I guess they're getting a PM from the payers for palliative kits for palliative care.
Yeah.
So they've rented 4 beds in their facility that always they have access to, et cetera, et
But
cetera.
I think now, I've also been involved with ACO work, and I can tell you that ACOs are realizing.
ACOs are what?
Are realizing that they need
Yep.
a SNF partner
Yep.
and to be able to provide palliative care. So you might be able to partner on a PM basis with a lot of SNFs. So ACOs are pretty much a modified MA plan now for traditional Medicare. So, and you're going to see a lot of ACOs. I think New Jersey is one of the largest. We have a lot of ACOs in here. And they, until now, did not want to partner with SNFs because they always said a SNF is a very expensive deal. But now they're really trying to get in and partner with them on the same per member per month.
And I might just add on that, and I'll contain myself. No. I think ACOs and plans are coming around to the fact that they're terrible at member engagement. Number one, they're terrible at member engagement. Number two, the amount that they know about their members is so much less than what you all know about your residents. They literally live in your facilities, and I think the smarter, and I don't want to pretend that all MA plans and ACOs are having this great awakening, but the smart ones are recognizing, hey, these individuals are living in this facility. We better work with the folks who have the data, have the eyes on them, and there are ways to partner to, again, help ensure that they stay out of the hospital, manage their use of super high cost drugs. So it's hospitalizations and drugs that really freak out the plans. And so partners who can help them manage that, they're going to be open to those
Do
conversations.
you think payers are open-minded to the concept of risk sharing?
Now,
Yeah.
absolutely. There is,
How so?
There has never been a time in the history of healthcare, I think, in this country that providers and payers are really partnering in the right way.
Including SNFs?
I'm telling you, the SNF is coming down the line. Providers, like the physician providers, were first ones because they are the easy catch to catch a physician and tell them not to do what not to do and what to do. But I think they are realizing now that they need to partner with post-acute services. They really do believe a SNF is a lower cost of care. So they do want patients coming out of the hospitals, going into the SNF, but they really need to make sure that a SNF is able to manage that.
Yeah.
that care of that resident. They don't want that person coming back to the hospital within 30 days.
You know, I just read that, this is unbelievable to me, the length of stay in the acute care setting of an MA patient is double that of a traditional Medicare patient. You would think the opposite, right? But
Except
it's
that
higher
they
because
pay
they
it.
can't move people, they can't
They
get
can't
the
move them,
approvals.
but they also get paid, they pay a DRG, right? So they're paying a hospital a lump sum, so they're fine, like, okay, let them stay in the hospital a little bit longer if they can skip the SNF or they can go home without home health, because they've already paid that, made that one
I mean, that's a big
payment.
opportunity for a SNF to say, hey, let us,
That,
right?
Yeah, or even say like skill in place,
Exactly.
and maybe they don't even need to go to the hospital.
Yeah.
Yeah.
But I think it is also, I think I read that same article, but it is also about prior authorization, right?
It's a big
the
issue,
MA
yeah.
is taking a long time to authorize a transfer to that.
Maybe on purpose,
And it is probably on
because
purpose.
those patients will go home without,
But you know what?
presumably nothing.
Traditionally, you have to understand from a payer's perspective that once the patient gets to a SNF setting, they don't get discharged. I mean, and we've seen it. You know, they don't go home, and so they are always worried about, you know, what's going to happen. And I think that is going to change, and that is what that is the metrics that they're looking at. Really, they're really looking at that.
Ryan, on the palliative hospice side, what are some of the common misperceptions of working from a SNF operator's perspective and working with a hospice, and what suggestions do you have to help operators understand what questions to ask or how to better partner with we were talking about MDS coding before, and you revealed some things I didn't even know. How would you address that?
Yeah, so, I think the way I look at long-term care facilities is that it's sort of the intersection of taking care of people and then taking care of people until they pass, right? And that's two different trajectories. You've got the short stay and then you've got the long stay resident. And I believe part of the nuanced approach that hospice needs to get better at is explaining our benefit to each of you on the long stay resident side of the house. So I'll give you a couple of statistics that you may or may not know being in the industry, but one is every 10% enrollment in addition to what you have for hospice reduces your readmission rate by 4.8%. That's a meaningful impact for you as providers and for you as that front line of defense for a lot of the residents. The second piece is, and we were talking about this as a group a little bit before, you have residents that are in your buildings today that their prognosis is 6 months or less. They are not going to get better. By keeping them off of hospice, you are actually getting hit with the quality measures, a degradation in your quality score. So by putting them on hospice care, and there's some tricks kind of behind the scenes with MDS and things, but it's very simple, you can get those long stay residents excluded from your quality measure score. And that's really meaningful for each of you because those residents are expected to decline. So in your world where you're trying to help them get better, and hospice, when it's put in place, can be really meaningful for you as a way to improve your quality scores. So that's a component that we're trying to get out in the industry right now as a partnership for you is reduction of readmission rate and then improving of your quality scores. I think that's a really good partnership opportunity as a whole.
A lot of hospice organizations now are providing palliative as a sort of, first introduction to clients to end-of-life care planning. First of all, I'm not sure if you have that, and if you do, how would you integrate that, or how can skilled providers take advantage of that?
Yeah, so at our company, at Gentiva, we have two paths, and I think we were talking a little bit before. There's this.
And Gentiva's in New Jersey.
Gentiva's in New Jersey, yes. We're nationwide. But you've got this fee-for-service traditional model in the outpatient environment, which is pretty standard, right? I think everybody knows it. You've all heard of players trying to get into it, and eventually they find out it's very, very challenging to make money in that world. But you do it because it leads to other things. So for hospice, it typically leads to an admission down the line of hospice care. When you look at the risk-sharing model that we had talked about a little bit before with Dr. Suri, that's where we as a partner can come in and share that risk overall with a for that resident. And it's a little bit nuanced in the nursing home world versus the community-based world versus the value-based world. That stuff is still getting out there, but overall, palliative care for your residents can serve as that conduit to overcome the initial fear of putting a resident on service, right? For our families and our assisted livings in particular, things like that, where they are just nervous, they feel like they're giving up hope. Palliative care is usually like, hey, just go on palliative, we'll get your advanced care planning needs met, we'll talk about your pulse or the different states' documents, but eventually that frontline caregiver, that advanced practitioner can say, it's time for you to have hospice from a little bit more of a trusting relationship.
Okay, great. And Ailyne, you were saying before the hospitals are like laser focused on palliative and hospice when you meet with them. Can you talk a little bit about that?
So part of the value-based program for some of the post-acute care center is really going into having hospice care services. So I think it's something that's coming up next year. So one of the biggest things that they're pushing is each facility must have some type of partnership with 3 different hospice company. So they are really making a really big push on this, on this piece of, I think it's always been there, but I don't think there's enough conversation nor have enough understanding on what hospice care is and the difference between hospice and palliative care. So that conversation is now starting, and it's more and more coming from the physician and also at the post-acute care, at the hospital level, and then it trickles down to the post-acute care center.
And not to mention the quality and patient resident satisfaction benefits, right, of having that additional set of eyes looking at your clients.
And we're actually just wrapping up a study looking at if patients elected hospice just 5 days earlier, what the outcomes would be. And we're looking nationally, and it's, I sound like I'm doing an infomercial for hospice here, but it's better for the patients, it's better for the family members, and it does yield savings. Not that that's the reason you would do it, but the extent to which they are moved out of curative treatment and moved into end-of-life care, there are meaningful savings. And I think that's another advantage that maybe the operators, SNF operators don't appreciate, that when a patient moves into hospice, you guys pay for all the services, the Medicaid, like you're taking that risk now.
Yeah, I think there's a misperception that to the long-term care world that when a resident goes on hospice, you lose money, right? It's a cost. It drains where you are. I would kind of challenge the opposite of that. I think it helps you if you're in a value-based world, it's going to help you because those residents, we know their readmission rates are reduced. But secondly, we pay for everything. We pay for the low air loss mattress. We pay for the high-cost medications. We pay for the longer, typically longer bedside stay from an aide, from a nurse. So we make you look really good when you've got hospice care enrolled because you get the credit for all of that wraparound service that hospice provides. But additionally, we can take some of the financial offset that can be really, really draining for those long stay residents that you have as they begin to decline.
Do you look at, I know the skilled providers look at who they use and recommend. I've been in the admission office, very recently actually with a client, and it's not uncommon at Friday at 4 o'clock to get a panic-stricken call from a hospice that they need to place a resident, et cetera, et cetera. How are hospice providers, or at least how are you looking at, I'm sure you're thinking about how do you align your quality partnerships, right, with SNFs that you trust as well, to use as a resource for clients who need it. And are people accessing that inpatient level of care as much as what I recall they used to?
Sure. So this is the care continuum at its best, I think, in my mind. And hospice allows for a benefit called respite care, which is what Tim is referring for. And that's a 5-day stay paid for by the hospice provider, paid for by Medicare. And usually that's a really good entryway for a family to see what a SNF world is like, right? And so we can place a resident in there typically in a time of crisis or when a family has some sort of emergency. We can provide, Medicare allows us to pay for a stay in your buildings for up to 5 days. And we look to our partners. We look for the facilities that work really well with us, where we've got care coordination meetings where we've got a good relationship, where we know we can put someone in. I will just share this with you, just as residents are so personal to each of you, in hospice, they are very personal to every one of us. We look at it as a gift to provide care to them as they are dying, and we want to put them in a trusted facility. So it really works out well, Tim, to your point of, we call you up, we need the help, that resident really needs help. It's a really good opportunity for the Continuum.
Okay, great.
The inpatient level of care that you're talking about.
Both respite and inpatient.
Yeah, so respite, you don't have to have any symptoms, any aggravation of symptoms, but inpatient level is when the symptoms are not managed at their current location, like their home or their assisted living. They can go into a SNF setting and get, and it's high reimbursement even for the SNF themselves. So it's a great benefit.
I guess, what would impress you, or what would you notice about a SNF coming to you and saying, hey, we'd like to partner with you? What would make a difference? Because, all providers are different, but, the goal of this is to understand how to align with our care partners in the community to not only do a better job from a care perspective, but to increase market share.
Yeah, I think just as you all want to have a network where you can partner with trusted providers, we want the same. So we want to have our patients go to the same few buildings where we have a trusting relationship with your DON, where we know your social worker, we know your unit nurses. It's a very personal interaction. So we want to create the same network that you do. And I will tell you, hospice, typically, I think right now the numbers are about 5% of residents utilize respite care. So that's a pretty meaningful impact. Every month, our 100 census providers referring about 5 patients a month to respite care. There's some studies out there that show how long those residents come back and stay in your building. There's some stickiness to it because there's a perception of what it would be like, and then you all do a fantastic job on your end of impressing that patient, and they end up staying. So there is that sense of family. There is that sense of long-term relationships that we're trying to cultivate as well.
But I think as a provider, and I don't mean to interrupt him, but as a physician provider, I think I'm looking for a facility that is pro-hospice, right? It's not just about, I don't want a nurse that is an agency nurse, goes in, sees a hospice patient and says, oh, patients in respiratory distress, get them out, and not look and do because the respite patients are there only for 5 days. I mean, I've had a lot of patients pass away on respite stays. So I don't want that patient out to the hospital, right? As a provider, I'm looking for somebody who's really, vested in that patient. So,
Are you seeing any trends in diagnoses for the post-acute setting? For example, everywhere I'm looking these days, there's articles and data being presented about the rise in behavioral health. What type of resources would you be looking at to judge if a SNF is adequately, able to care for a lot of these patients?
it's a sticking point, I think, everywhere. But I think most SNFs partner with a psychiatry group, and I'm almost certain they do. Whether it's a physician or a clinician, like a mid-level.
Are you seeing a rise? I'm sorry to interrupt. Are you seeing that rise in behavioral?
Oh, absolutely.
Yeah.
We all know that the patients who have either underlying dementia or have a psychiatric diagnosis will utilize the emergency room and have higher hospitalizations, 50% higher than the general population. So, a lot of them actually have undiagnosed dementia or cognitive deficits, and they're coming to the emergency room, don't have a diagnosis, but clearly have dementia. So you do need a very good partner, but so for us, we actually go to a psychiatric hospital, want to stay on top of all of this, but what has become in the skilled nursing, and I'm seeing a lot of trend in the other specialties as well, is that somebody's coming in, checking the boxes, GDR is not appropriate, GDR is appropriate, but I don't think there is a lot of education about how to handle patients with dementia and their behavioral. And, every time a patient acts out, they go to the emergency room. And that is not appropriate, right? You really need to train your staff to deal with this because this is what your world is going to look like going in. You know, our geriatric population is aging. Dementia is supposed to double, by 2030. So I think a lot of our population is going to be somebody who's going to have a behavioral health component to them. And I think we all need to learn how to manage it. Your staff needs to be trained. Your social workers need to be trained on how to talk to families about this. And they also need to be able to teach the families how to deal with it when they discharge the patient.
Yeah, and I would even say, and I don't know about how this is playing out in New Jersey, but we've worked with a number of organizations that have said, not only are we going to do the training and make sure that we can handle these cases, we actually have an underutilized, mothballed unit or facility we're converting to behavioral health. Now, that, there's a whole set of regulations and reimbursement, so I don't want to pretend that that's an easy step, but we've seen this in a number of markets, and in fact, one client we work with has a inpatient psychiatric facility that is a geropsych specialty. They actually have a bridge over to the skilled nursing facility, and they will bring over that staff for patients that don't need to be in an inpatient psych facility but are, exhibiting serious challenges, and, they want to have that intervention before they just say, okay, get them out, send them away.
By the way, this is not just skilled nursing. I see some AL providers in the audience. It's also relevant, probably maybe even more relevant for some of the assisted living providers that are struggling with increased acuity.
Yeah. I will say on the AL side, there's also, there is a Medicare program called GUIDE that is a dementia care program. Unfortunately, folks living in long-term care facilities do not qualify. But yes, there are a lot of assisted living operators that are kind of waking up to this. It's a physician-led program, and I could nerd out on it. I'm sure we all could. But it is a recognition. I think what's important for the long-term care industry is that it is the first big effort at the federal level to focus on dementia care.
Alzheimer's, yeah.
They pay for respite care. They pay for caregiver
The respite
training.
care is not, SNF residents don't qualify for respite?
They don't qualify to become part of the GUIDE program and get the dementia, kind of the wraparound
Right.
dementia care
But
services.
if someone's at home, GUIDE could pay for a SNF stay, respite.
Home and assisted
Right,
living,
yeah.
independent living, yeah.
They can bring them to a SNF. They can actually bring them to an ALF or
Yeah.
provide home care, all three.
If they qualify. Fred, are you following the Teams model?
How much? Here we go. Yes.
So tell everybody maybe a little bit about it
Yeah,
and what
so-
they should be preparing for.
Yeah, so the team model, very quickly, is a bundled payment program that the federal government will be implementing January 1, 2026. I should have done my homework before and figured out it's not in every market in the United States.
New Jersey it is.
Yeah.
Yeah.
New Jersey's typically targeted.
Yeah. For good reason.
It's a high spend. It is high spend. And basically it is, so think of it this way. Hospitals right now get a DRG that covers the entire hospital stay. So if somebody comes in with a hip replacement or hip or femur fracture repair, the hospital gets paid a lump sum that covers the entire 5, 6, 7, however many days it is. The team model is basically saying for certain conditions in certain markets, which New Jersey, you guys, congrats. Those of you working in New Jersey get to be part of this. The federal government's basically saying, we're going to pay you a lump sum payment that is supposed to cover the hospital stay and 30 days of post-discharge care. So it's essentially a bundle payment program. Well, not essentially, it is a bundle payment program, and the hospitals are now accountable for the spend on patients who they discharge to your setting for 30 days. Hospice is actually included in there, home health. So if you've been following other Medicare programs in the past, bundle payment programs, those have been voluntary. Let me be very clear, this is not voluntary. This is mandatory. It starts January 1st, and it includes hip and femur fracture repair, hip replacement, major bowel procedures,
CHF.
spinal fusion, and then CABG, cardiovascular or cardiac bypass surgery.
That's wild. Hip fracture, every patient is different. You know?
Yeah, and hip fracture, when you look at the data, and I promise I'll rein myself in here, but with hip fracture, when we look at like the total amount of spending over like a 30-day episode, including the hospital, the surgery, the hospital stay, and then post-discharge, post-acute care counts for like, let's say 60% of that. So you better believe the hospitals are going to be looking at this and saying, oh boy, at best we manage 40% of this. 60% of those dollars we have not been really paying attention to, we really haven't been accountable for, we will be now. And they are forming, Ailyne, like you were talking about, forming those narrow networks. And we know this because we're helping them.
You know,
form
I
those
actually
networks.
was with a hospital a couple weeks ago, and they didn't know about the Teams model. We actually presented it to them. So I
Yes.
think there's an opportunity.
There's an opportunity.
to get
Well,
ahead
case
of
in
it.
point, we were talking to a hospital executive, and we were getting on the phone to talk about team, and I could hear him typing, and he said, "Oh, transforming episodic." I was like, "Oh boy,
Yeah.
we have some learning to do
You're
here."
going to actually see the provider reimbursement also. So a lot of SNFs have started partnering with consultants. The consultant, unless it's really needed, will not get paid for it. So it's part of the Teams model. They if
Are you
there
talking about
is-
the physician consultant?
even a physician consultant. So if there is already a cardiologist that is in the hospital and you call a cardiologist now in the SNF, that cardiologist is not going to get paid for it. So it's all coming, it's because there's one reimbursement for the whole thing. And the reimbursement is at the Medicare Part A level. The physician is not going to get paid. So, consultants coming into the buildings and doing 20 consults, they're going to see a big change as well.
Ailyne, what barriers are you seeing to sort of get approvals on admissions these days? We were talking about AI. Actually, you mentioned you're working on a new system. Can you talk about that?
So on that part, coinciding with the rehospitalization problems or readmissions within this model, one of the things that we're trialing to see if an AI program can generate a summary of a patient pre-admissions. So we have certain criterias for the number and the risk of the patient. So we're looking to see if that AI program can generate a number scale. The higher the number is, the more at risk the patient on readmissions. So then on pre-admission, we can already alert our entire team to say, hey, according to this program, this patient's percentage of rehospitalization is very high. Now add this patient to your line list of being able to seen by the provider, on a weekly basis or on a daily basis. I think with the point of the Teams model, I think that is also one of the reasons why the acute care hospitals are really pushing to narrow down the post-acute care network, because they want to be able to monitor where the patient is going, who's sending patients back out to the hospital, which post-acute care center is keeping the patient, because it's coming. Like you said, January 1st, we have seen this, we've heard about it, and there's just multiple aspects of it. And I think for iSNP plan, it's one of the things that Optum iSNP plan is really pushing back on a lot of the consults these days. And it's basically saying, hey, if you're seeing this patient, you're no longer going to see this patient, every week or every month. You're going to have to see the patient every couple of months, according to this model. Medical necessity, yes.
Based on this is a question for all of you, if we can go kind of round robin, what programs do you think SNFs should be thinking about in terms of, not today necessarily, but I think one thing that the provider world forgets is that we have this humongous surge. We're going to be 20% of the population in New Jersey, and across the nation it'll be over 65 for the first time in 2030. And to me, the issue is not about how are we going to keep our occupancy high. The issue is going to be we don't have enough beds. But there's dialysis, there are behavioral units. What other type of, maybe palliative what other type of services do you think that providers should be thinking about to, differentiate or stay current with some of these value-based initiatives
Yeah, I think, we've
or
talked.
resources that they've built into their operations?
Yeah, it's interesting because we've been talking a lot about accountable care organizations, which are programs targeted primarily at Medicare fee-for-service patients. And, the SNF's kind of traditional viewpoint of ACOs is, oh, well, that's hospital XYZ or physician group XYZ that has this ACO, and now they're coming to us and saying, hey, if you want to be part of our network and get referrals, you need to adhere to these performance standards. And you're right, it is very active here, particularly active in New Jersey. There are a lot of those ACOs.
And Fred, I'm sorry to interrupt. Those performance standards usually are rehospitalization and length of stay?
Yeah, rehospitalization, length of stay. They also, and we won't get into how awful this is, but they use the star rating. So they'll typically say like baseline 3-star, ideally much better than that. But yeah, they do use star ratings.
So that's the top three.
Those are the big ones.
Yeah.
It's actually spend also.
I was
for
going to say,
SNF.
do they look at
Yes, there is a lot of, SNF spend is a big piece of it. I mean, because I'm working on these models with Optum. So, just overutilization of, your consultants, wound care. Wound care is big right now. So
good point.
I think
But
those.
Go ahead.
Oh,
I'm
sorry.
Yeah, go ahead.
I was just going to say, what a lot of folks don't realize in the long-term care world is there are a whole bunch of long-term care focused ACOs. And it's a different world. It is where a physician group is coming to you and saying, hey, we are going to form an ACO. You can be a part of that. We are going to build it around your residents. And we are, in lawful and legally compliant ways, going to help share in the savings if you can help us reduce readmissions.
For the long-term clients or the short-term stay?
Long-term.
Long-term.
Long-term. So think of it as you've got a lot of, and I think this is the bigger story here, and I think some providers have been aware of this, or clued into this, but it's really thinking about, you've got a lot of long-stay residents. Medicaid is going to be challenging, can become even more challenging, but every one of those residents, virtually 100% of them are on Medicare. And Medicare right now is spending, it's probably going to be like $30,000 to $35,000 a year on your long-stay residents. And there are very meaningful opportunities to be a part of managing that spend. Part of it is maybe through an ISNP if you want to go down the Medicare Advantage path, but in states here like New Jersey where Medicare Advantage just is not as big, you've got a lot more Medicare fee-for-service residents, you can be part of an ACO that is managing those residents, and you're getting more of the upside, not just being part of the network. It's also, if you keep costs below a certain spending benchmark, you get some of the savings associated with that. So it's a really different business model.
Thank you. One of the other dynamics that I've recently read about is that the MA plans, Medicare Advantage plans, have almost double the rate of observation stays in the acute care setting. So I'm wondering if you feel that how does that impact us? Because they're not necessarily beholden to the 3-night rule. Have you seen any trends in that area, Ailyne, or opportunities? You can say no.
Not necessarily trends on it, but I think, most MAs does not require the 3-night stay. It's more so, the authorization process becomes more difficult.
But they clearly don't want to admit.
Correct.
Right?
But the prior authorization process, I think, is the more challenging one because the patient is on observation. So the way they're seeing it is, okay, patient is on observation. Why does the patient need to go to a skilled nursing setting for, the patient stayed for 2 nights or 2 days at the hospital?
What is the outlook? We don't have necessarily, I know you're a home health provider in a sense, Ryan, but we don't have home health on the panel. What is the outlook for home health? This is to everyone, but Fred, if you want to.
It's pretty rough right now.
Yeah?
Anybody in the audience have home health agencies?
Is that good for SNFs?
No. I think because the extent to which you need to refer out to home health gets harder. Home health agencies have really been hammered by Medicare rate reductions. And I also think there's been a bit of rebalancing in terms of home health utilization. They face the same workforce challenges. I would argue in some markets we work in even harder, if you can believe it, than long-term care to, reduce their vacancy rates, reduce turnover rates. So they've got all the labor cost and labor management issues, but reimbursement has really taken a major hit.
Are the home health Medicaid residents in the community under the same mandates as the SNF residents? For example, does the state have to cover long-term care home under Medicaid?
Oh, so Medicaid, yeah, and that is actually one of the big things that we anticipate happening. So the Medicaid home and community-based services, HCBS, so think of personal care, AL waivers, right, assisted living waivers, basically Medicaid programs that aim to keep folks out of nursing homes and in the community. We anticipate those programs are really going to get hammered as a result of the new legislation that was passed, because those programs are not mandatory. So states are not required to cover those services. They are required to cover your long-term care services. So we anticipate that in a number of states, they will scale back those home and community-based services, which you could argue, hey, that means more folks that will need our services. Okay, that's good, but you're still going to have the staffing issues. In fact, I think staffing is going to be exacerbated by some changes in the legislation. So it is going to put a squeeze on you all, and yeah, we've looked at this in the past when the federal government has reduced Medicaid spending. The states figure out, well, what do we have to pay for, and what could we pay for but don't have to now? And they don't have to pay for services in the community; they have to pay for nursing home care.
So thank you all. We're running out of time. I wanted to turn to anyone in the audience if anybody had a specific question for any of the panelists. Yes.
So that's great, because we actually are working with one SNF down south that has a lot of substance use. Optum iSNP program is developing programs internally. We've actually hired a psychiatrist who's been a substance abuse psychiatrist for a while. We've hired staff, internal staffing, because obviously these people are going to the emergency room. They don't get to their cocaine and they can, the staff has cleaned it out, they're just going to go to the emergency room. So one particular, I think, SNF, I don't know if they're here or not, but has been experiencing a lot of it. So like I said, the trend now is that the providers, the payers are wanting to talk to providers more than they've ever done in the past. So if you have a particular need, you really need to bring it up, and they are really vigilant, and they want to make the change, because for them also, Medicare is putting a lot of burden on them as well. The V28 that came out with the HCC scoring, they also are seeing a lot of cuts. So they also need to manage. They also need to manage their spend. They will develop programs specific to your needs, but it is important that you communicate.
I didn't mean to interrupt. Just to add that the MA plan, one of the beauties of the Medicare Advantage program is those plans have the flexibility to invest in that. I think the reality is, it's such a great point, and honestly, I think from a policymaker's perspective, I haven't seen a lot of efforts to try and integrate. They treat them as two very different worlds with different agencies and different funding. I wish I had a better story, but I think that's the reality.
Well, I want to give a plug to the panel. I've worked with all of these folks and currently and in a past life, and they've all added tremendous value to anything I've been involved with, I'd encourage you to reach out to them directly after the panel. And thank you all so much for your time. Thank you, guys.